Now I'd like to introduce a very remarkable young woman, Rosa. Time to come down. Rosa did a presentation yesterday to the medical community, and she has spent quite a long time redoing it today, so I appreciate all her hard work. Rosa Michaelis is a medical student at Witten-Herdecke University in Germany, where she is focused on the treatment of epilepsy. She has conducted studies at facilities across the globe, from the University of País Vasco in San Sebastian, Spain, to London, to the Oregon Health and Science University in Portland, Oregon. Now, Rosa will be studying here in Toronto, at Toronto Western Hospital, right, for the next month. Outside of the lab, she remains active in the medical community. She's volunteered at a clinic in Northern Ireland. She's tutored medical students in Tirana, Albania. In her spare time, she plays violin, she studies yoga and practical philosophy. Now, she has performed very important research on epilepsy. She studied Donna's case files for several months, monitoring her work and reviewing her files. She will be sharing this research and the results for the very first time today, and welcome.
Good afternoon, everyone. Is that all right here with the microphone? No? Closer? When I first found out about the Reiter approach to epilepsy, I actually didn't know a whole lot about epilepsy. I knew that it had to do with seizures, and I don't have seizures, but when I started my first internship in surgery, I used to faint regularly in the operating room. So I would get cotton in my head and like crystals would appear. And then after a while I would wake up on the floor looking at the ceiling with all those people bending over me, telling me that everything was all right, and I thought, well, nothing is all right, it happened again. And I seriously questioned my ability to become a doctor because of this. So I don't want to compare fainting with having seizures at all, but I tell you this in order to let you know that I can kind of relate to the feeling of loss of control. I also knew that about 1/3 of seizure patients would not be able to get control over the seizures by taking medication. And I also knew that there was a big issue with anxiety and depression in the epilepsy population, and that because of seizures and side effects of medication, many epilepsy patients were not able to work properly, and so they did not have the money in order to spend it for other approaches to epilepsy rather than drugs and surgery. So, when I first heard about the Reiter approach, it intuitively made a lot of sense to me that it would work, because it was just getting straight to the point. Loss of control, take control of your epilepsy. And agency is the keyword here. And in German, we say that this approach kind of puts you in the position to operate at eye height with your disease. And not only with the disease, but also with the therapist, because every case is so individual that actually you teach the therapist something about your condition. And I at least can say that today, while you were sharing your questions and stories, I learned more about epilepsy than I ever learned in any lecture at medical school, and I really appreciated that. So this method really describes the kind of doctor that I want to become, a doctor who who gives responsibility to the patient and recognizes the patient's ability to know what's best for him or herself. and I want to learn from my patients. And when I said that the Reiter approach made sense to me intuitively, that's a wonderful thing. Intuition is, from my personal viewpoint, intuition is a wonderful tool in order to know what's right or wrong. But in my case, there's a problem. I'm a med student, and I'm not supposed to base my judgment on intuition, but I'm supposed to base it on scientific proof. And there is even a word for that kind of medicine that I'm supposed to do, which tells me not to rely on my guts, but on other people's brains. That's evidence-based medicine. And what we learned this morning, it's common sense-based medicine. So I personally don't need the scientific proof for this. I'm perfectly fine with intuitively understanding that this works. But unfortunately, professionally, I do need a scientific proof. And I can imagine that this also applies to some of you, that you want scientific proof. Because I can imagine that many of you have already tried many things, and you might have gotten disappointed. And now, before you put your trust again into something else, you want to make sure that this trust does not get disappointed. And also, insurance companies want scientific proof. Otherwise, they won't pay for something like this. So when Dr. Alsos offered to me that I can go to California in order to collect the original data of patients that were treated by Donna Andrews, I remember sitting down with the biostatistician at the university where I study. And a biostatistician is something like the personified opposite of intuition. And he, I told him what I wanted to do, and he looked at me and I said, well, the success of this treatment highly depends on the patient's motivation, right? I was like, wow, this guy, this number guy, he got it. Yeah, it depends on the motivation. Isn't that great? And he just looked at me and said, I advise you not to do it. Because it's going to be an awful lot of work, and at the end, this tiny, unpredictable element is going to screw it all up. Well, then I took a deep breath, and I said, okay, when we're going to do this, in order to convince people like him, we really need a very conservative, a very vigorous approach to this whole thing. And now, let me tell you. I presented the data that I'm going to present here. I already presented it once to the chief neurologist and the chief epileptologist at the hospital where I'm working right now in Germany. And they said, well, you approached this stricter than any drug trial ever that I've ever seen. And in that case, I took that as a compliment. And our results are better than the drug trials. And that is why I stand here in front of you right now. I mean, talking about the Reiter method it's super interesting, and talking about scientific methodology is very boring compared to it. But anyway, I will go through the study with you. And and I study medicine because I really like one-to-one interaction, and I like to listen to people. And standing here in front of you is the total opposite of what I like. So I'm totally out of my comfort zone. But I do that because I think that you ought to know the results of this study in order to decide for yourself if you want to do this or not, and so that you can base this decision not only on your intuition, but also on scientific proof or scientific backup. So let's start this. I collected data in order to analyze changes of seizure frequency in patients who were treated with the Reiter approach to epilepsy. And as you've heard many times today already, trigger self-control and seizure arrest constitute two very important elements of that. So where exactly did I get what kind of data from? Between 1980 and 2010, Donna Andrews treated approximately 2,500 patients. The majority of those patients the data of those patients was not available for research use, but an intensive protocol was offered to patients who were not living within commuting distance of the practice. And after 96, this intensive version followed a uniform protocol. So therefore, in order to select a homogeneous, comparable study group, we obtained data from the patient files of those 135 patients. And those patient files contained all kinds of data that were used in order to evaluate the reliability of the diagnosis of epilepsy and the probability of additional non-epileptic spells. Why? Because that was the first objection that we expected from conventional neurologists reading the paper. How do you know that the people that were treated really had epilepsy? Why don't you think that they just had some sort of psychiatric condition? Because the conventional neurologist thinks that this kind of approach only works for psychiatric patients and not for epilepsy. We were mainly interested in the development of seizure frequency during the course of the intervention, and so we compared the number of seizures during the first 8 weeks of the program with the number of seizures during the last 8 weeks of the intervention. But we did not only try to assess the decrease of seizures, but also the increase of times without seizures by comparing the percentage of seizure-free weeks during the first and the last third of the treatment. And we only analyzed data of periods with the same or decreased medication. We did that because if you observe seizures and they change, and people did this approach and at the same time they increased the dosage of their medication, then you don't really know what's responsible for the change of seizure frequency. And someone might just say, well, the drug made the difference, so we paid attention to that. And yeah. In order to ensure that we were working with high quality data, we set up a bunch of inclusion criteria that the patients had to meet in order to be included in the study. And on the basis of those inclusion criteria, we had to exclude 73% patients from further analysis. And here you see the characteristics of the patient group. It's important to point out that more than 2/3 of the patients had already tried at least 2 anti-epileptic drugs, and that makes them drug refractory, which then means that the chance that drugs will ever help them to become seizure-free is pretty small. Also, the majority of patients with complex partial seizures had a bilateral onset of seizures, which makes them non-surgical candidates. Some of the patients had already been operated on, so they were still having seizures. And this means basically that the majority of patients could not expect any help from conventional medicine anymore, because those are the main tools to address epilepsy. If there's a physical problem, we cut it out. If there's a functional problem, we give a drug, and if that doesn't help, well, we can't help you anymore. We're sorry. The majority of patients identified physiologic factors like sleep deprivation or hypoglycemia that affect the whole brain and lowers the seizure threshold, or internal or external seizure triggers. And I included this table in order to illustrate the range of unspecific and specific seizure precipitants that were identified by the patient during the initial patient assessment. And it is especially striking how many patients identified emotional stimuli, stress being the number one seizure precipitant. And that's also something that conventional neurologists do not believe, that emotions actually trigger seizures. And stress, of course, is a rather general term, so that was the task of the patient during the course of the intervention to really figure out what that meant in the individual case. And while I obtained this data, I stayed with Donna, and I learned a lot from Donna. And one of the things that I learned was that there is no such thing as an unprovoked seizure. And neurologists talk about this all the time and say, oh, sorry, ma'am, you have to take away your driver's license because you had, according to our criteria, you had an unprovoked seizure. But what that really means is that they could not find what they were looking for, but they did not look hard enough to find what caused the seizure. The majority of patients identified a warning sign, a prodrome, or an aura. And more than 2/3 of the patients who had identified a warning sign during the initial patient assessment reported the interruption of seizures during the course of the intervention, usually by using deep diaphragmatic breathing. Now we'll get to the main outcome of the study. Comparing the number of seizures at the beginning of treatment with the number of seizures during the end of the treatment, the number of seizures in 3/4 of the patients had at least been cut in half, and about half of the patients were seizure-free by the end of the program. And some of them had already been, by the end of the program, had been seizure-free for up to 8 years. And I will tell you a little trick how to look at this data. The neurologists, they look at the second group because those are the patients with definite epilepsy, but I mean the results are pretty much the same in all groups. But that's the really hard data. I know this table looks everything but exciting. But it tells you that there was a large increase of weeks without seizures during the program. And just as you did, we asked ourselves the question, if the Reiter approach is useful for patients with nocturnal seizures, with primary generalized seizures for children, and patients with an IQ of less than 80. And unfortunately, the patient numbers were too small for statistical analysis, but looking at the individual outcome we found, in each group we found improvement of seizures and some patients became seizure-free. And of course, before we draw any conclusions from all this data, we have to look at the things that limit our ability to interpret this data. But I don't want to go through this right now. And the only thing that I want to mention is that we did not have objectifying instruments to evaluate the changes in quality of life, but there were many illustrations and email extracts and the diaries that showed that there was an improvement of quality of life in the patient's life. So, despite all those methodological limitations, bottom line is that patients who were drug refractory or non-surgical candidates or had already been operated on, they were seizure-free by the end of the intervention. And that is why we think that our data suggests that the Reiter approach is a therapeutic option not only for drug refractory patients and non-surgical candidates, but for all motivated epilepsy patients. And drugs and surgery have side effects. A side effect means, what you want is a decrease of seizure frequency. What you get is also a lot of negative things on the side. And if you take this definition, the Reiter approach also has a side effect. It does not only decrease seizures, but the side effect is an improvement of life quality.